Welcome to the Weekly Neurology Deep Dive. Just a reminder, this deep dive is for educational purposes only. It has no commercial goals, and it's just a summary of a research paper. For the full picture, make sure you read the complete original paper. Today we are going to examine a study on the effects of repetitive transcranial magnetic stimulation,
Or rTMS?
rTMS, yeah, on cognitive impairment in patients with amyotrophic lateral sclerosis.
ALS.
ALS, right?
The research that you highlighted, the effect of repetitive transcranial magnetic stimulation of the dorsolateral prefrontal cortex on the amyotrophic lateral sclerosis patients with cognitive impairment. A double-blinded, randomized, and sham-controlled trial by Wenzi Zhang and colleagues. They wanted to investigate whether rTMS could actually benefit ALS patients that are experiencing cognitive difficulties.
So not just the ALS, but the cognitive issues too.
Exactly. And they also wanted to look at the impact it had on caregiver burden, disease progression, and some specific biomarkers.
This was a double-blinded, randomized, sham-controlled trial, and it involved 80 ALS patients with, again, cognitive impairment. It focused on 4 weeks, either 10 Hz rTMS or a sham treatment, and it was applied to the bilateral dorsolateral prefrontal cortices.
The DLPFC.
DLPFC, right?
So the primary outcome that they measured was the rate of decline in the total ECA score,
Which stands for?
the Edinburgh Cognitive and Behavioral ALS screen. And they looked at this over 12 months.
Okay.
And then for their secondary outcomes, they included changes in what's called the Zarit Care Burden Scale.
For the caregivers.
For the caregivers, yes. The ALS-FRSR total score.
Remind me what that stands for.
The ALS Functional Rating Scale revised, and then also neurofilament light chain plasma levels.
Oh, interesting. Okay.
So let's unpack some of these findings and talk about what they mean for you in your clinical practice.
Sounds good.
So who exactly were the patients included in this study? Inclusion criteria. Right, they had to be 18 years or older. Diagnosed with clinically definite or probable ALS. And that's according to the revised Ellis-Scorial criteria, meaning they had upper and lower motor neuron damage in at least 2 spinal cord segments.
Had to have both.
Yes. It was crucial that they had both. And of course, they also had cognitive or behavioral impairments.
Which we've been talking about.
Based on the ECS. Specifically, they had to have a cognitive scale score of 105 or less, or a behavioral score of 1 or greater.
Okay. And did their breathing capacity matter?
It did. Their forced vital capacity had to exceed 75% of the predicted value. They had to be breathing well enough to participate.
What were some reasons that a patient might be excluded from this study?
If they had a tracheostomy, that was an exclusion criteria. Certain implanted devices, like if they had a cochlear implant, a pacemaker, metal implants, deep brain stimulators, or a vagus nerve stimulator.
Wow. So a lot of different implants could exclude them.
Pretty much. If they had any other neurological conditions like a brain tumor, epilepsy, brain trauma, schizophrenia, other neurodegenerative diseases, those were also exclusion criteria.
Makes sense.
Also, pregnancy or breastfeeding, that was an exclusion. And a prior history of TMS or cognitive function training therapies.
Oh, interesting. Okay. So for those that were included, can you walk me through the rTMS intervention?
Sure. The rTMS involved a 10 Hz stimulation at 90% of the individual's resting motor threshold.
Okay.
And they applied that to the bilateral DLPFC. Each side received 1,500 pulses daily for 5 consecutive days a week.
Okay.
Over 4 weeks total.
Got it. And how did the sham control work in this study?
The sham group received a placebo stimulation. The coil was angled 90 degrees away from the scalp, so it basically mimicked the sound and the sensation of the rTMS, but it wasn't delivering the actual magnetic stimulation to their brain.
Interesting. So what were the key findings in terms of that primary outcome, that ECS score?
The biggest takeaway was that there was a statistically significant difference in the ECAS total score, and it favored the rTMS group compared to the sham group.
At all points in the study?
At the 6-month and 12-month follow-up, specifically the intention to treat population.
Okay, so for the 6-month follow-up, what were those scores?
At 6 months, the rTMS group scored 81.98, plus or minus 6.51, versus 76.16,
The sham.
plus or minus 6.26 for the sham group. And that was a p-value of 0.031.
Okay, and then at 12 months?
The scores were 79.22,
4
time
times,
and
right.
plus or minus 6.50 for rTMS, and 75.39,
Sham.
plus or minus 6.24 for sham, and that p-value was 0.042.
Interesting. Were there any specific cognitive domains that seem to be more affected by the rTMS?
Yes, the significant differences were observed in the verbal fluency and executive function domains of the ECS, but there were no significant differences found in the language, the memory, and visual spatial domains.
So more like thinking and speaking.
Yeah, exactly.
Interesting. So let's move on to the secondary outcomes. What impact did the rTMS have on caregiver burden?
The Zarit score, which remember is that measure of caregiver burden, decreased significantly in the rTMS group at 3 months and 6 months after treatment compared to the sham group.
Do you have those specific numbers?
Yeah. At 3 months, the rTMS group scored 52.24 plus or minus 3.34 versus 50.32
Sham.
plus or minus 3.21 for sham. That p-value was 0.003, and then at 6 months, it was 56.42,
For rTMS.
plus or minus 3.41 for rTMS versus 53.60, plus or minus 3.22 for the sham group, with a p-value of 0.014.
So that suggests it could help alleviate some caregiver burden, at least in that short term.
It really does.
What about the ALS-FRSR scores? How did those change?
There were no significant differences between the rTMS and the sham groups when it came to the ALS-FRSR scores, and that was at 3 months, 6 months, and 12 months, which indicates that the rTMS really did not impact the physical severity of ALS during the study period.
Interesting. So it seems like it was really helping with those cognitive symptoms, but not the physical progression.
That seems to be the case, yes.
What about those neurofilament light chain levels?
There weren't any statistically significant differences in the plasma neurofilament light chain levels, so that's NFL, between the two groups at 6 months and 12 months. Those p-values were 0.051 and 0.084. But even though there wasn't a statistically significant difference, the treatment group did show a trend of those NFL level rates kind of decelerating over the first 6 months.
Huh. Okay. Interesting. Were there any other interesting correlations between the different measures?
There were some significant negative correlations between the ECAS and the Zarit scores, and that p-value was 0.016. ECAS and ALS-FRSR scores, p-value of 0.008 there, and Zarit and ALS-FRSR scores, and that was a p-value of 0.025. But there was no significant correlation between those plasma NFL levels and ECS scores, and that p-value was 0.329.
Okay, so a lot of connections there.
Definitely.
Now, when it comes to using rTMS, of course, we want to talk about safety. What did this study find?
They assessed safety using the SAFT scale, and there were only 3 mild side effects reported across both groups. One rTMS patient had some mild nausea, another rTMS patient had pain at the application site.
From the coil, you mean?
Exactly. And then one of the sham patients reported back, or neck pain.
Interesting.
But importantly, there were no serious adverse events reported at all.
No seizure.
Including seizures, yeah.
That's great. So for neurologists out there that are listening to this, what are the key takeaways from this study? What's the practical application of this research?
Well, the big thing is that this research suggests that rTMS of the DLPFC, that area of the brain we've been talking about, it could offer some short-term cognitive benefits for ALS patients, specifically the ones that already have cognitive impairment.
Especially in those areas of verbal fluency and executive function that we were discussing.
Yes, exactly. And there's also that added potential benefit of reducing caregiver burden, at least in those initial months after the treatment. Remember, the data showed statistically significant improvements in those ECS scores and a reduction in those Zarit scores.
Especially in the rTMS group, and particularly within those first 6 months.
Right.
So that's some really promising data for those patients.
It is. But of course, there are some things to keep in mind.
Some caveats.
Right. It's really important to note that this study did not show a huge impact on the physical progression of ALS.
As measured by that ALS-FRSR.
Exactly. And there weren't statistically significant changes in the NFL levels over that 12-month period either. And even the researchers themselves, they acknowledged that there were limitations to this study.
Like what?
The sample size, for one.
Could have been larger.
Yeah. And they also didn't have genetic testing results for all of the participants, so that could potentially have influenced the interpretation of these findings.
Sure.
And they also highlighted the need for more accessible TMS equipment, so more people could potentially benefit from this intervention.
It would be great if it was more widely available. So this deep dive gives neurologists some valuable data to think about when it comes to using rTMS to manage cognitive symptoms and support caregivers of those ALS patients that have cognitive impairment. But as always, remember to consult the full original paper to make sure that you have a complete understanding of this research.
Always important.
Thanks for joining me for this deep dive. We'll see you next time for another weekly neurology deep dive.
Looking forward to it.